Good afternoon, everyone. This is Gloria Sachdev. Welcome to the Employers Forum meeting. It's a pleasure for us to be hosting these meetings over Zoom. We are getting better with the technology all the time. I'm so grateful to have Sarah Oddie on our team, who's now a Zoom expert. And I'm on my way. I was just telling our guest speakers, I hope by next year that I can get through one of these without, totally messing it up. Oh, look, now something's already showed up, a whiteboard of some sort. So I don't know. Sarah, can you see the screen okay?
Yeah, I can see my slides. I think we're okay. Yeah.
Okay. Great. Well, why don't we go ahead and begin? So welcome again, everyone. We're really excited to have this discussion today. We are going to be talking about surprise billing, and you'll hear quite a bit about what surprise billing is, what other states are doing in this space, what opportunities exist for Indiana. So last legislative session, surprise billing was addressed. The Employers Forum was very supportive of having surprise billing addressed, and there's been a commitment from some of the legislators to further address it next session. And so we'll have an opportunity to welcome your thoughts regarding what needs to be done and how we should proceed. Kristen Royer normally would be moderating our session. She's the chair of the forum and she's on vacation today or this week, so she sends her regards. Just a couple of business updates. Sarah, if you could go to the next slide, please. Just wanted to share with everyone our upcoming all stakeholder meetings. So on August 19th, another policy opportunity is to talk about anti-competitive language that are in the contracts between carriers and providers. One of those is gag clauses, which we did address this past legislative session, but there are, the idea is that you prohibit gag clauses from being in these contracts so that the purchasers of healthcare can have information, can know what the negotiated rates are and other claims-based information. However, there are lots of other clauses, and we'll hear from subject matter experts from UC Hastings and Dan Bird, who was the lead attorney against Sutter Health, who was sued for anti-competitive language. But they did settle out of court on that for $575 million. But anti-competitive language includes things like most favored nation, all or none, anti-tiering, anti-steering, and the like. September 18th, registration is now open. We just opened it up in the last couple of days, so please register for this meeting if you're interested. We will be sharing the results of the RAND 3.0 study. It's an all-day conference. We have Chris Whaley from RAND presenting. We'll have folks from Quantros presenting. Senator Braun will be presenting. We'll have a group of executive provider panel group, employers, and some policy folks sharing their thoughts. So a really exciting agenda. We do have a conference agenda. You're welcome to check that out. Registration's free. We have a grant from the National Institutes for Healthcare Reform funding this, so it's open to the whole country and free to the whole country. Up to a max of 3,000 people. That's all the webinar can handle. November 13th, we will be talking about healthcare racial bias and the impact on healthcare delivery, talking a little bit about what we've done this past year and looking ahead as well. So please join us for all of these all stakeholder meetings that are coming up. Sarah, can you go to that next slide? So now it's my pleasure to introduce to you our two national subject matter experts that are known for surprise billing. We have Loren Adler. I'm just going to read his bio here for you. So Loren is Associate Professor of USC-Brookings Schaeffer Initiative for Health Policy, a partnership between Economic Studies at Brookings and the University of Southern California Schaeffer Center for Health Policy and Economics. His research focuses on a range of topics in healthcare economics and policy, including insurance markets, provider payment, prescription drugs, Medicare, and the Affordable Care Act. Previously, he served as research director for the Committee for a Responsible Federal Budget and as senior policy analyst for the Bipartisan Policy Center. Adler received his bachelor's degree in mathematical economics from Wesleyan University and his master's in applied economics from Johns Hopkins University. We've had the pleasure of working with Loren over this past legislative session. He's published widely in the space of surprise billing, and really we look to both him and Jack to guide us in some of our recommendations if it made sense, and kind of how we should proceed. As many of you may remember, Paul Ginsberg helped us a couple of years ago when we were talking about looking at value-based payment models, and Loren works with Paul at the Brookings Institute. So Jack Hoadley is Research Professor Emeritus in the Health Policy Institute of Georgetown University's McCourt School of Public Health. He retired in 2017, but continues to conduct research on a part-time basis. In 35 years as a health policy researcher, he has studied a wide range of health financing topics focusing on Medicare, Medicaid, and private health insurance. His main area of research currently is state and federal consumer protections around surprise medical bills. Other recent papers have addressed the Medicare Part D drug benefit, access, costs, and coverage for prescription drugs, Medicaid coverage for children and families in small towns and rural areas, and the impact of provider concentration. Dr. Hoadley served 6 years as a commissioner on the Medicare Payment Advisory Commission, commonly known as MedPAC, from 2012 to 2018. MedPAC, as many of you know, it's an independent, nonpartisan committee that is responsible for providing the recommendations of how Medicare pays for services. He holds a PhD in political science, prior to arriving at Georgetown in 2002. He held staff positions at the Department of Health and Human Services, MedPAC, the Physician Payment Review Commission, and National Health Policy Forum. Please join me in welcoming both of our speakers. And before we get directly into it, we have 2 polling questions for everyone in the audience. So you're going to see 2 polling questions. Sarah, if you can bring those up.
Yep.
And while she's doing that, I want to call everyone's attention to the chat box. Please feel free to enter your questions in the chat box. If you want to ask your question directly, just put it in the chat box and Sarah can unmute you only one at a time. Unfortunately, on Zoom webinar, she can't unmute everyone at the same time. So here are the polling questions. If everyone could just click the answer and then scroll down to the polling question number 2 and answer it. And we're just going to show everyone the results here. So let's just take a couple of minutes to do that. And you can scroll down independently on your own, each of you, using your mouse. I've learned that today.
Loren, if you want to get up your slides while everyone's doing this, that might be good, so we're all ready to go. I'll leave it open until I have a majority of people responding, but I don't want to take too much time away from Loren's presentation.
Sounds good. So the first question is, what % of your patient-covered lives population do you believe surprise billing occurs? Again, if you're a physician group or a hospital, what your patient population, if you're a health plan, a benefits consultant, employer, you can answer for your entire population that you cover. And you can scroll down and see the second question with the responses. So which of the following statements best describes your observation? So emergency services for this question means air ambulance, ground ambulance, and emergency department. And non-emergency means elective care at an in-network facility. You want to show the polling results?
Yeah, we have about 20 more people left to respond. I don't know if you wanted to wait a little bit more or we'll just...
Okay, we'll give them 5 more seconds. I'm so generous, right? 5 seconds.
5 seconds.
I saw Loren laughing. 5 seconds.
Okay, I am so sorry if you have not been able to complete it, but I am going to end the polling and share the results with everyone.
Wow, so I'm a little surprised by this. So we have 21% from 1 to 3%, 15% 4 to 6, 27% 7 to 10, and the majority you believe it's happening in more than 10% of, I would have put a greater number had I known that everyone thought it was going to be a greater amount. So Sarah, I want you to screenshot that so I can have that as a post question for another group, and we can compare them. Can you show the polling answer for question number 2?
Yes. Save this. You might be able to scroll down.
Oh yeah, we can scroll down individually and see polling question number 2. So it seems that it's happening primarily in emergency services more often than non-emergency, but for many of you about the same, you believe, and then for some of you, you know, it's happening in inpatient, in-network services, so out-of-network practitioners and in-network facilities. All right, terrific. So let's go ahead and have Loren pull up his slides. We'll have one more polling question after Loren's presentation, and then we'll have one polling question after Jack's presentation as well. And then we'll open it up for Q&A. Loren, you are on mute.
Sorry about that. Thank you for having me. As Gloria mentioned, I'm Associate Director of the USC-Brookings Schaeffer Initiative for Health Policy, based at the Brookings Institution in Washington, D.C. Happy to be here to discuss this important topic with you. A lot of I do research on a broad array of topics, but a lot of my life over the last few years, as the sort of issue of surprise billing has really hit the news, has been on this issue of surprise billing. So I've at least gotten to dive into it a lot, and I've worked mostly at the federal level with lawmakers and folks like that, but have done a fair amount of work at the state level as well, especially the last 3-4 years. There's been a lot of state action on the issue. So just to start out, I'll sort of discuss kind of what surprise billing is, how common it is, and then sort of get flip sides to sort of talk about the solutions and Indiana's specific approach towards the end here. So first, I always just like to start with the definitional question here, because I think normal people refer to surprise bills as a very wide array of things, from just being in your deductible to sort of the definitions that we may sort of policymakers think of in the surprise billing context. But for sort of the issue that's sort of at the heart of the policy discussion right now, we're really talking about sort of a few specific situations. So one is pretty much any out-of-network emergency service, whether that's the ambulance that takes you to the hospital itself is out of network, or any clinician as part of your care at an in-network hospital happens to be out of network, whether that's the emergency doc or the plastic surgeon, whoever that might be. That's probably the most common one, as I guess the polling seems to indicate here in Indiana as well. And then the other one is just sort of the non-emergency care at an in-network facility. So you go in and get a surgery, you make sure that the surgeon is in network, the hospital is in network, but then it turns out that the anesthesiologist or a pathologist where your lab was sent was not in your insurer's network. And similarly, you're stuck, you can be stuck with the insurer pays something, and the provider can then balance bill for the difference between their charges and what the insurer allows in that situation. So those are kind of the focus of the sort of specific instances that I'm talking about in this context. And these are not, there's been a lot of great reporting on all sort of the anecdotes here, but I think the data we've had in the last few years shows that this is more than just a series of anecdotes. This seems to be a pretty common occurrence, where roughly 1 in 5 emergency department visits involves a patient being seen by at least one out-of-network provider as part of their care. And even about 1 in 10 times when you do that second scenario where you go to an in-network hospital and then a network surgeon, still about 1 in 10 times you're going to be treated by an out-of-network anesthesiologist or an assistant surgeon or another type of doc. And then for ambulance services, it's even higher. Actually, the ground ambulance one I think is even higher than this, but it varies a ton state by state. and air ambulances are just almost always out of network across the country. So this really is a pretty common problem, right? What we're identifying here is just when you're sort of inadvertently treated by an out-of-network provider. Obviously, in some of these instances, the provider doesn't actually send a balance bill at the end of the day, or at least in the work we've done, it seems like the employer or insurer actually just sort of pays full charges about a quarter of the time that this happens. So, and about half the time in air ambulance services that they end up just paying the full charge, with seemingly little regard to like how expensive the charge is. So fundamentally, I like to sort of go to why does this occur? I always like to start out there. So fundamentally, in my view, sort of the fundamental market failure here, as I would term it, is that there is separate contracting for the hospital and for the clinicians who work at that hospital. That is somewhat odd when you're talking about clinicians that patients don't actively choose, for that to be sort of the possibility of discordant network status there. In sort of, I think most human beings who think about this issue think that when I go to a in-network hospital, I think they all think every doctor there should be in network, but certainly when I pick a surgeon that's in network, the anesthesiologist should sort of be part of the care that I am buying when I go there. And because of that, the possibility for discordant network status, you get in a situation where certain types of specialists can basically remain out of network without losing the same patient volume that a cardiologist or a neurologist or someone who's sort of treating patients who are proactively choosing them. And because of that, they can kind of stay out of network and try to make out of network billing a actual strategy. And I think the data so far is pretty clear that there are a sort of minority of providers out there in specialties like emergency medicine and anesthesiology who clearly make this a strategy, while the majority are really trying to be a network. And most hospitals that I talk to are pretty strong that they make sure that every doctor at their hospital, or at least every ancillary physician at their hospital, is in network with all the same plans they accept. But I think the example that gets trotted out is a lot is there is this company called MCare, who's owned by a big private equity firm. And there's very clear when they, at least back in the mid 2010s, it was very clear when they entered a hospital, they purposely canceled all their contracts with insurers, jacked up the charges a ton, and either got, I think back in the day, a lot of insurers were just paying a percentage of charges for out-of-network care, or started balance billing until insurers were willing to pay them more money to bring them back in network. And I think this slide right here is just sort of showing, unsurprisingly, the specialties who have this ability to remain out of network and sort of rely on high charges to sort of make a lucrative out-of-network billing option have some of the highest charges compared to other specialties. So we really see, particularly in anesthesiology and emergency medicine, that the sort of average charges in those specialties are far higher multiples of what Medicare pays than other specialties, and in particularly at the top end. So you can see here, there's about 1 in 5 anesthesiologists has a list price or a charge that's more than 11 times what Medicare pays. This is pretty astronomical in the scheme of things. I don't think anyone's necessarily arguing that Medicare rates are perfect, but they are at least our best attempt at trying to estimate what the sort of the efficient cost of delivering the services. And I think once you're in the 11 times range, I think you're pretty clearly in. This is not a market type of rate here. And similarly, this isn't just the sort of list prices. This at least appears to flow through to in-network rates as well. So similarly, we see, anesthesiologists, pathologists, radiologists, or your hospital-based specialties and emergency medicine all get in-network rates that are, 200, 300, 350% of Medicare on average across the country. Indiana looked pretty similar, at least for anesthesiology and emergency medicine when I was looking to the national averages here. But, compared to across all physicians, there's different estimates out there, but, somewhere between 1.3 and 1.5 times Medicare is sort of what other physicians are getting. And right when in-network rates are high, that flows through to premiums that we all pay. I think it's hard to like pinpoint an exact estimate here, but you very potentially are talking about a couple percentage points of premium when you're sort of talking about the leverage that the threat of surprise billing provides, and also in turn sort of what a sort of good solution might be able to help with. So now sort of turning to the solution side of things. I think first I like to lay out sort of what I view as the key elements of a comprehensive solution, sort of looking at this from a state level, in this instance, given the audience here, and given that it seems like federal lawmakers are dithering on the issue. So I think first and foremost, when we're talking about these types of specialists who it's really hard to imagine patients ever actively choosing their anesthesiologist. And I don't really, that doesn't really seem to make sense, or, when they have a heart attack, choosing which doctors incubate them seems like a pretty hard thing to imagine. So taking patients out of the middle here, I think, is very important. They shouldn't have to initiate the action. Some states have sort of put it on, you can balance bill the patient and the patient can like fill out 10 forms and get it all fixed. But I think that's sort of a bit much to be putting on the patient here. And similarly, I think in general, trying to limit exceptions to surprise billing protections to the extent possible. So for instance, I really can't think of a situation where we should be allowing ambulances or anesthesiologists to be balance billing anyone. So I think, trying to sort of limit the sort of notice and consent type exceptions that often pop up in laws here. Sort of going forward, also, I think it's important to be comprehensive. That means applying both to emergency services and those sort of non-emergency services that happen at in-network facilities, and including ground ambulances in that as well. If we're talking federal level, I would say including air ambulances additionally, but at the state level, that's unfortunately preempted by federal law. Similarly, applying this to all types of health plans. In the past, a lot of states just applied this to HMO products, but there's really no evidence that this is sort of more common in different types of products, and especially the lines between HMO, PPO, EPOs have sort of all gotten blurred in the last 10 years anyway. And then lastly, this is sort of something I always like to harp on when talking with folks at the state level, is that states really do have the ability to protect self-insured plan enrollees as well as the fully insured, even though no state but Indiana has taken that approach to date. And then lastly, I always like to also harp on trying to avoid policies that are just going to increase health spending. It's nice to protect people from surprise billing, but if the solution is just to, say no more surprise billing, but we're going to require insurers and employers to pay, something like charges, that's not really solving a problem. You're just sort of shifting the costs and increasing them into premiums rather than individuals getting surprise billed. So I always like to break down sort of the buckets of solutions, because I know Indiana has sort of acted on this already, but obviously there's a lot of states and the federal government that's working on this. So I think it's useful to kind of break down the two broad buckets of solutions here. So one is what I at least call contracting regulation. And this just means you are effectively saying it is illegal to balance bill patients. And I think in my view, the sort of cleanest version of this is what at the federal level, when discussed, has been termed the in-network guarantee. And this really says, as a condition of working at a facility, if you're an anesthesiologist or an emergency doc, you have to join all the same health plan networks that the hospital accepts. And it basically with the hammer of if you don't do that, then you can't balance bill patients and you can't bill the health plan, effectively sort of roping the hospital into this negotiation, or the ASC. I think from my view, especially if you think of an anesthesiologist, their sort of main market is actually with the hospital that they work at, rather than the insurer in most ways. It is, right? It's when if I was an anesthesiologist, what hospital I choose to work at, that is really what is guaranteeing me the flow of patients that I get. And similarly, obviously the hospital needs anesthesiologists, or else they're not much of a hospital. So there's a very clear market dynamic that can be had there. And I think we very clearly see in the data today even that basically that anesthesiologists are already having a financial negotiation with hospitals over the subsidies or the medical director fees that are being, and the stipends that are being paid today. And then the second one that's listed here is just, you just literally say it is illegal to balance bill for some subset of providers. And I'll jump into this more because this is the approach that Indiana took. I think this works out effectively the same way, but there are some question of how courts might interpret it when there is no requirement on the insurer for what to pay. I think the clear benefits of this, especially from the state level, is that because these are fundamentally, these are regulations on the provider rather than on the insurer, these protect state residents in self-insured plans as well as fully insured plans and avoids ERISA preemption. To me, that is sort of the most attractive feature here. It also sidesteps the need to create a benchmark or arbitration process, which seems to slow down everything elsewhere. And from my view, this is kind of the cleanest way to, right? I said the market failure is that we have separate negotiations. This between for hospitals and for anesthesiologists, this just makes it one negotiation. You have sort of created an actual market here without sort of the need to intervene with sort of elements that smell of rate setting. Sort of diving a little deeper here, I kind of alluded to this, but the Indiana law takes what that number 2 approach there. So in my view, so it only actually applies to non-emergency services, the law that was passed this session. So it basically says, if you are a out-of-network doctor at an in-network facility, you are not allowed to bill the patient for any more than what their in-network cost sharing would have been. And from that perspective, the insurer's requirement shouldn't really owe much of anything. If anything, maybe they owe, they probably end up paying the in-network rate, and then the provider can't balance bill on top of that. But again, because that is a regulation on the provider, that should protect all residents all commercially insured residents in Indiana. Right, there are notice and consent exceptions within that law, which is one of the somewhat, a smaller sort of loophole within the law. I think going forward, at least my view personally, is that there's probably some limitation that can be placed on those notice and consent exceptions. As I was mentioning before, and sort of the approach that the federal lawmakers have taken is we try to make a blanket prohibition on balance billing for, the doctors where there's really no reason you would want to see an out-of-network of that specialty. So for anesthesiologists, emergency docs, really anyone in an emergency situation, applying sort of a blanket ban there, and then just having a notice and consent exception for other types of providers, and ideally making it so that there has to be some sort of verbal consent. That's typically kind of the gold standard of sort of the patient protection angle within notice and consent exceptions. And sort of the big thing is the Indiana law does not touch emergency services. So it is still possible to surprise bill for emergency services. With an exception, there's an old law in Indiana that I think potentially may protect folks in HMO plans, but that seems to be a small part of the market here. So for everyone else, extending for me, I would extend the exact language that passed this year, extending that to out-of-network emergency services, I think would be attractive. When you get into ground ambulance regulation, at that point, once you're talking about ground ambulance, because there's no sort of hospital intermediary there, at that point, you do need to figure out some way to add a requirement on insurers to pay some minimum amount to them, based on in-network rates or what have you. Then lastly, I just wanted to touch on quickly, this is sort of my less preferred approach, but this is the other bucket of approaches that I term billing regulation, is what every other state has done and what the federal government is sort of working on. It's similar, but really the fundamental, so it's still, there's a ban on balance billing. You require insurers to treat the out-of-network care as in-network for purposes of cost sharing, deductibles, co-insurance and so on. And then you also determine some minimum out-of-network payment requirement. And that is either you can set what's called the benchmark, where you say insurers have to pay at least their in-network rate for this service, or you set up an arbitration process to effectively farm out that decision and sort of let arbiters decide what the benchmark is. Personally don't see much of a rationale for arbitration, but if you're doing it, I think there are ways to make it less administratively costly, and sort of providing guidance that they should be looking at in-network rates or Medicare rates is sort of ideal here. My one sort of biggest warning in all of these is just really not to base anything on charges. They are, the list prices here are extremely high, as I was showing earlier, and really are completely untethered to market forces. So that's sort of my main caution in working on this, but hopefully there will be another push at extending the Indiana regulation to emergency services next. And I think my view is sticking with the contracting regulation approach is actually the most attractive here. But with that, I will stop and turn it over to Jack, or Gloria can intervene and introduce him in the meantime.
Excellent. Thank you so much, Loren. I have a question before we get going, and if others have questions for Loren, they can put them in the chat box before we head to Jack. So one of the things you mentioned was that the notice or limitation recommendation for Indiana on our good faith estimate. So with our surprise billing legislation, there is, you mentioned, like a small loophole, which some may not call it a loophole, but they would say, there is this exception, if you will. Mm-hmm. And the exception is that patients, if they want to pay an out-of-network provider that out-of-network fee, the out-of-network provider must provide a good faith estimate 5 days before the scheduled procedure. The patient has to see it and sign off on it. And you mentioned that, this could be a piece of paper that's buried in a stack somewhere. They may be mistakenly, and they're, just may mistakenly, sign off on this. And so there's concern. What are your recommendations for how we can mitigate that a little bit? You mentioned you mentioned verbal consent. Mm-hmm. Would they document somewhere that they obtained verbal consent? Or I wonder if you could just elaborate on how we could shore that up a little bit.
Sure. And I can, Jack's welcome to chime in here as well, because I think he's thought probably actually even more about the notice and consent type rules than I have. But yes, fundamentally, I think that there would have to be some marking down, and you could challenge if you have to sign something saying that you were verbally notified of this. That's sort of the idea here. I agree. So I think there is value in having the sort of exception process for some instances, right? There's some doctors who, work a couple days a week at a hospital, and they may be out of network, and you may want to see the out of network premier cardiologist or whatever it might be. I think that's a reasonable thing, and that should be allowed. I think my view is I can't really think of an instance why you would do that for an anesthesiologist. Right. So I think you can kind of blanket apply things there. But for this, yes, I think the verbal consent is helpful. I also think just sort of the Department of Insurance keeping an eye on this is useful. Or I guess actually really this needs to be provider regulation. So someone in some part of the government needs to sort of be keeping an eye on what is happening here. Making it as clear as possible to the patient what is going on is just important in these instances. So that's sort of it's unclear that it will get, abused. I think a lot of states have exceptions, not unlike these. I think a lot of it is about enforcement, how much it actually gets abused or not.
I appreciate that. I think that's right. We heard in testimony last session about a case, if you will, a fictional case, but if there was an orthopedic surgeon and then the patient wanted their neighbor who happened to be an orthopedic surgeon to do the procedure, that should be the case. But as you've shown us, that it's really not happening with cardiologists and orthopedic surgeons. It's happening with anesthesia, pathology, radiology, assistant surgeon, and emergency room physicians the most. And we don't pick those people, right? So it would be, And cutting out emergency room physician, because this isn't for emergency services in Indiana. Yeah, patients and Hoosiers don't select those providers. So maybe we can look more closely at our enforcement. Jack, do you have any comment on that question?
Yeah, I was just going to say, I think you've got one of the important ones in having the 5-day advance. So the real problem is you show up in the hospital for your scheduled procedure, you're handed that sheaf of paper to sign a bunch of things. If it's just included there, that's where it's most likely to be a problem. If you require this to be done some days in advance, then you're not signing this while you're already in the gown, laying on the gurney or something like that. Having the cost estimates also valuable, because it says, okay, my additional cost for doing this might be so-and-so. And I think Loren's right that a verbal notice, the same way we expect doctors to, explain the health risks of a particular procedure verbally, not just on the piece of paper, but they usually sit there and walk you through a few of the key points. That's the same notion here that can be helpful as well.
Awesome, thank you. So appreciate, Loren, that presentation was awesome. And we're going to switch it over. Oh, actually, we have a polling question before we switch to Jack. So Sarah, can you pull up the next polling question for our participants?
Nope. Everyone should be able to answer now. So, sorry. So since there is only one polling question, I will probably leave it open for a minute and a half, maybe less.
We don't need to leave it open for a minute and a half. There is, it's a really short question. Yeah. The thing with this technology for me is a minute and a half, maybe it just feels like 15 minutes for me. So I
totally understand. I will let a few more people, I'll give everyone 5 more seconds. And then we will, okay, I am sorry to anyone who was not able to answer the polling, but I am going to end it and then share these results with everyone.
Okay, so it seems like it's interesting. We had a couple of people that don't agree, or maybe, depending on what the N was on that, a couple of people that don't agree, but most people, by and large, agree that we should extend what we've done in Indiana to surprise billing in emergency situations. So that's good to know. Excellent. Jack.
Okay.
You are on. Thank you so much for being here today. And maybe you'd like to introduce yourself a little bit before you jump in.
So, thanks for inviting me to be part of this. As you mentioned earlier, I'm at Georgetown University. I'm supposedly retired, but obviously continuing to do work on some of these things. We've been doing, I'll show you a slide in a minute that shows you how long we've been working on these issues, but we are providing technical assistance to both state and federal policymakers, as well as tracking. And most of what I'm going to do today is really talking about what states have done across the country, and then a little bit on the state of play with federal legislation. So just make my slides advance here. There we go. So just kind of repeating what Loren talked about in terms of some of the strategies, and maybe just putting a little bit of my terminology. We've got the issues around prohibiting balance bills. We've got the provisions around holding the consumer harmless, making sure that the consumer doesn't pay anything more than in-network cost sharing, and that's often done as a requirement on the insurer. If you just have a hold harmless provision, that's less protective if consumers may not be aware that they're protected. So that's why it's important to have the billing prohibition as well. In addition, a lot of states have done disclosure requirements, but we think those are not fully protective because consumers often don't understand what they're being told, or they're in a situation where they can't change their behavior or may not have enough information. So again, the strategies around determining payment that Loren mentioned, there's both the reimbursement benchmark, and I'll talk more about what different states do, but that's the notion of setting some kind of a reimbursement rate based on Medicare, based on contracted rates or something else. And then secondly, states use independent dispute resolution in order to provide a way to set a rate. And as I said, we've been working on these for over a decade with funding from a number of different sponsors. We're currently tracking state laws with support from the Commonwealth Fund and providing technical assistance, as I mentioned, with support from the Arnold Foundation. And a major part of what we've done is to survey all of the state laws and regulations in place through the present day. To do that, we define a concept of comprehensive protection as making sure that a state extends protections in both emergency and non-emergency settings, that they apply their laws to all types of insurance, at least all types that are subject to state regulation, so both HMOs and PPOs, protect consumers by some kind of a limitation in network cost sharing, and then in our definition of comprehensive, we want to see states adopt either or both a payment standard or a dispute resolution process. And this shows you what states have done to date. There are actually now 16 states that we classify as having comprehensive protections and another 14 with some kind of partial protections, like Indiana, that doesn't really deal thoroughly with emergency cases. And other states that are in that less than comprehensive may have left out one part or another. They may deal with emergency, not non-emergency, or vice versa, or they have other things that they haven't done. But that still leaves about 20 states plus DC that don't have any kind of laws in place at all, except possibly a transparency or disclosure law. This continues to be an active area for states. And so we saw 5 states enact laws in 2019. We've seen 3 already fully enacted into law in 2020, including Indiana's. And Georgia is all done except for the governor's signature, and he's committed to signing that as we understand things. And still a number of states that are still considering measures this session. So state activity continues to be active. I want to illustrate sort of the 3 different ways that states are doing things. You know, states all pretty much agree on the basic protections, holding consumers to in-network cost sharing, at least in the settings that they address. But where they differ is on payment rates. And we've got a number of states, such as the 5 listed there, that use a rate standard as their primary approach. Some of those also include some kind of a smaller role for dispute resolution, but those states primarily rely on a rate standard. And they may either use a predetermined rate schedule, like offering a % of Medicare, that's what California does, or some other kind of rate standard. And that's a method that obviously has the most certainty because it's a publicly known schedule, it's transparent. Some states use a public benchmarking database, such as an in-network rate based on a state all payers claims database. And that's more of a market-based approach. Instead of basing it on Medicare, this may be more attractive to some folks because it's an amount derived by the marketplace. And then third, some states use insurers' internal data, tell each insurer that they have to pay the provider, the out-of-network provider, based on their typical in-network rate. Then there's another set of states that primarily relies on dispute resolution. So you see some of the examples there. New York was the first to do that, New Jersey, and then 2 of the more recent states, Virginia and Washington, have gone this route. Some of those states do require an initial payment using some kind of a rule, such as a commercially reasonable rate. So the idea being you still want to get an initial payment out on a prompt basis, and that's attractive to providers. Out-of-network providers feel like, you know, they may be delayed in getting paid, especially if it's an arbitration approach. And then the key elements of dispute resolution typically are using a best and final offer or a baseball-style arbitration approach, requiring some kind of preliminary negotiations, again, to try to encourage settlements to be made without going through the formalities of arbitration. Having a minimum dollar threshold to say only claims above a certain dollar amount are eligible for arbitration. And then something like a loser pays method that, again, creates a disincentive. If you don't really have a good case, you're encouraged not to go on through dispute resolution. And then finally, what are the factors that the arbitrator may consider? And one of the factors that can be included, as Loren mentioned, is to not look at charges, but to perhaps encourage the arbitrator to look at some network or some database of in-network rates. And then the third set of states uses a hybrid approach. We've sometimes called this the split the baby approach. So it combines an initial payment based on a payment standard with an independent dispute resolution if the parties find that the payment amount is not acceptable. So Colorado, Florida, Georgia, and Maine are all the primary examples of these hybrid approaches. And then states like Virginia and Washington have some elements of a hybrid approach. And states have turned to this, and we've seen more interest in this lately because they address some of the weaknesses of each of the separate approaches. You don't have all of the cost of arbitration if many of the things can be settled by simply making a prompt payment on a payment standard. But where providers object to the payment standards, there is that out of using arbitration. And it has proved in a number of states, like Georgia most recently, as an opportunity to get political compromise among stakeholders and get something done. And in Indiana, as Loren talked about, which has something of a different approach, and he's covered most of the elements here, but again, non-emergency services, state prohibits billing of the enrollees beyond in-network cost sharing, protections are to all types of services, and then the consent exception, and we talked about that, so I won't say more. And Loren's made this point as well, that the prohibitions apply to providers. They're not, the law is not written on insurers. And so it does seem that this protects enrollees of self-funded plans. And then I will mention this earlier law, which I've given you the citation for there, that applies to HMOs only and does require insurers to hold enrollees harmless and prohibits the network providers from billing. It is unclear how many people this applies to because it only applies to HMOs. And it is also unclear how much or if these provisions are being interpreted or enforced by the state. We've tried to talk to some of the state regulators and it's just unclear how much of a role this is playing, but I did want to include it. So then saying a few things about some lessons learned from how states have done things. You know, some states have narrowed the applicability of their laws by saying, for example, Washington state says that when you're in the non-emergency setting, it only addresses a certain list of specialties. Now, those do include the anesthesiologists, the radiologists, pathologists, ER docs, and so forth, the most common ones. But some folks in Washington have noted that they wish, in hindsight, they would have included NICU doctors as one category of something where you normally don't pick. You're just assigned to the NICU and the doctors show up and do the work. Not all states have addressed out-of-network hospitals in emergency settings. So, you know, there's kind of an assumption that you somehow get to the network hospital, but of course you don't really control what hospital you get to. And so some states now have begun to try to fill in that loophole. Ground ambulance services have been excluded in most states, like in Indiana. But there are a few states, Colorado notably has attempted to address this. And then no state really can address air ambulance services because of the federal preemption, although there's been some efforts to try to do it, mostly unsuccessful. There are exclusions in many states for some of the newer types of insurance, like short-term limited duration plans that aren't subject to a lot of other state regulations, so sometimes those are left out. And then the ERISA plans are left out in most states, although there are a couple of states, notably Washington and New Jersey, that have voluntary opt-ins for the self-funded plans. I mentioned before that a solely disclosure and informed consent approach tends to not work very well because people don't really understand, and that's why most states that have tried that have moved on away from that and gone to something more protective. We've also talked about the limits that are imposed by consent-based exceptions. A lot of states don't have that kind of 5-day advance notice that Indiana included. And in Texas, they almost ended up with a rule that said they would have allowed doctors to just put this on a piece of paper that's handed to you at the point of admission to the hospital. But in the end, they didn't go that route. There's also a few states that have required overpayments if a doctor does bill you for the full amount and it turns out that they weren't allowed to, that they are legally required to refund those overpayments. And then one of the issues that's come up a lot is what's the enforcement authority? Which agency of the state government has the authority to enforce and what tools do they have? And that could be a whole another discussion. And then other policy considerations that states have tried to think about is what's been the impact on the healthcare system? Does this affect plan provider network negotiations? How is it related to network adequacy requirements? What's the overall impact of health costs and premiums? Also, a number of states have put in reporting requirements that ask states to report out the results, how many complaints still seem to be emerging, what are the results of arbitration, and so forth, as well as asking them in some cases whether they see any evidence of impact on network adequacy, network negotiations. The research, because so many of these state laws are new, the research is pretty limited. In New York, with an arbitration approach, there have been stakeholder studies by one of my Georgetown colleagues finding that most stakeholders believe the law has achieved its primary goal, but the views are more mixed about the overall impact. And some newer evidence, Loren is responsible for much of this, that insurer payments to doctors may have increased as much as 5%, perhaps because of the use of charges as one of the arbitration factors. In California, with a rate setting approach, the medical community has published information on anecdotal reports of fee reductions, indicating their concerns. Insurers have suggested that there's evidence of more in-network providers. But those are all interested parties making reports. RAND did a qualitative analysis that suggested a fairly mixed view among stakeholders about the impact. And then Loren was part of the study that suggested that there was, in fact, fewer out-of-network claims, suggesting that maybe this has had a positive impact on physicians signing up for networks. But the real bottom line is we just don't have a lot of evidence, and something we need to see more on. Then I want to turn just briefly to the federal law. The reason we have interest in Washington on a federal law is that there are still 20 states without any laws and other states that don't have comprehensive laws. For the most part, no state jurisdiction over self-funded plans, no ability for states to deal with air ambulance service. And then one particular issue, which is services received in another state. So if you're on a border area, you're in Portland, Oregon, but you go across the border into Washington State to get your health care or vice versa, it's unclear in which laws apply. So we really have seen 4 different committees pass bills in the last 12 months, including a compromise that was informally announced by the Senate Help Committee and the House Energy and Commerce Committees last December. And we really were in the process of seeing those committees begin to negotiate out their differences when the pandemic hit and everything kind of stopped happening. I'll very briefly talk about some of the differences. The bills are very similar in terms of covering all the settings. Both the Senate Help, Energy and Commerce Compromise Bill and the House Education and Labor Bill do have air ambulance provisions, but all 3 of them exclude ground ambulance, although one does have a commission to try to look into it. They share the goal of limiting consumers to in-network cost sharing and banning balanced billing. Where they differ is that the first 3 bills, the Senate Help, House Energy and Commerce, and Ed and Labor, all primarily use a payment standard with a median in-network rate that's locked in for 2019 and then inflated for the future. They have a backup arbitration, so they do have that hybrid approach for cases over $750. The Ways and Means, by contrast, is more reliant on mediation, and that's their primary method. That parties are encouraged to reach a voluntary agreement, but after 30 days, they can go to independent mediated negotiating process. They all share the notion of excluding billed charges from the arbitration and allow median and network rates as one of the factors, as well as some other information. And then finally, all 3 of the bills would defer to state laws. So any state like Indiana that has a law in place, the payment standards or the absence of a payment standard would remain in effect. I actually don't know quite how the Indiana one would interact. That's something we'd have to look more into. And then there is some reliance on states for enforcement, with federal enforcement as a fallback, although the Ways and Means is more directly based on federal enforcement. So again, we had a lot of progress in the last 12 months in the Congress until the pandemic slowed things down. There were attempts to bring it into some of the COVID relief bills. There were a number of states that did provide some emergency relief for the pandemic, some cases actually expanding the coverage of their existing laws, others just urging protections. And then the federal government did do things to effectively preclude balanced billing for COVID testing. And then any recipient, any provider that receives federal provider relief funds may not balance bill. And so just to close out, looking ahead, I think there's still the possibility of federal legislation this year, but it feels not super likely. They'd still have to reach a compromise and find a legislative vehicle, maybe during the lame duck session after the election. Undoubtedly, state action is going to continue, and as I mentioned before, we still are seeing states working on things. And some of the states, like Indiana, that don't have everything covered, have a tendency to come back year after year. We've seen that in a number of states, where states go part of the way one year and then come back in a future year and fill in their gaps. For Indiana, there's the obvious need to address emergency services. There's a question, I think, of whether payment amounts should be addressed, whether there's any concerns around that. Perhaps clarification of the impact on the self-funded plan enrollees. I don't know if there's been any rulings or publicity out of the state agencies to talk more about that. And then a question of how enforcement might go. I have some of our citations on 2 other slides, and those can be made available to you after the session. With that, I'll stop.
Excellent. Thank you so much, Jack. That was wonderful. Really broad overview of what's happening around the country. Everyone's welcome to put questions into the chat box. And I have a question for you. So where laws are in place, how have states attempted to enforce the protections and make sure that consumers are fully protected?
Yeah, that's been an interesting issue. We have explicit language in some state laws that make a balanced bill an unfair business practice. And so that's one means that's used. In other cases, there's been specific authority given to the state attorney general to look into cases. But it feels like in most of the cases, it's more somebody's got to call attention to this. There's not necessarily anybody out there monitoring on this on a regular basis. And so consumers or insurers could play a role in this. Self-funded employers could certainly play a role to identify if they see cases of balanced bills, making them known to state agencies and trying to make sure that they're enforced. Some have specific monetary penalties. So there are some provisions, but it's something that I think states have been struggling with, and we hope to do more of a look into what some of the potential enforcement mechanisms might be.
Yeah, all this is so new relatively. It sounds like just based on what you mentioned, there haven't been a lot of analyses conducted. I mean, we have the majority of the states in the US have something in place, but maybe Loren, it sounds like you've done some work, both of you have, in this space of looking at impacts. Could you elaborate? You mentioned there's been an impact or maybe a preliminary impact analysis on costs, looking at the New York arbitration model, and that costs went up by 5%, or prices, I should say, healthcare costs or prices went up by 5%. Maybe you can clarify which one that was. And then in the California model, where they looked at a percent of Medicare as the payment benchmark, seems to show that healthcare costs, based on the study that I read of yours, Loren, and you can talk to it, it seems like costs were trending downwards based on an earlier study, and that more physicians actually went in network. So I don't know, Loren, if you want to take that first, and then Jack, maybe if you have any thoughts on it as well.
Sure, I'm happy to. So yeah, so I have more research underway, but primarily I've taken at least some look at the laws in New York, New Jersey, and California. Only some of the results are actually public at this moment, but the New York one, since we're just publishing it as a working paper, I guess I can sort of relay that. Should be out soon. But that one, so New York has an arbitration model, and they through regulation sort of told arbiters that they should consider the 80th percentile of charges in the market. So, more than charges higher than what 79% of doctors bill for that code. So that ends up being a pretty high amount. And I mean, just sort of from the data that the state has released, the decisions pretty much track exactly with that with the sort of the very high benchmark there. So we have a paper actually finding out that allowed amounts from insurers went up 17% in New York compared to control state. Compared to other places in the U.S. So having a pretty significant effect, it seems like there. The California one is much less certain. So I think there's a very clear move that we see where there's a clear sort of jump in network, where the law seems to have at least helped get doctors in network. To date, however, there's sort of not great evidence on what the impact on actual payment rates has been. We'd love to look at this. We've just sort of been stifled a little bit by data limitations. I think despite the fact that that like half of states have now passed a law, the sort of issue from the data researcher perspective here is that almost all of them are passed in the last few years. Yeah. At least the ones with benchmarks or arbitration processes and sort of like clear guidance on what's actually happening. So it's just insurance claims data, which is sort of how I do these analyses, is sort of released on quite a lag. So I have like 2017 data is the most recent data I have. So there just aren't that many laws that were enacted, before 2015, which is sort of what we have to work on. So I will be continuing to do more analyses of states. I'm curious to look at Oregon, who's another state that uses a benchmark at median and network rates, very similar to what the federal laws are. So I'll be looking at that next year at some point, but it's really just it's been a data limitation problem so far.
Excellent. Jack, any final last words?
Yeah, no, I think that's really helpful research, and I think it's already been influential as states and certainly as federal policymakers have realized that it's important to exclude a charge-based standard in an arbitration process and to avoid it in any kind of rate standard. And so to try to, there's been a lot of attention to making sure that whatever kind of payment standard is used should not be inflationary. And we've actually got CBO scores that seem to support that notion.
Yeah. Well, it looks like there's a lot more work to be done. We look forward to reading your papers that will be coming out shortly. Our session doesn't start till January, so your great work can help influence us. We plan on keeping in touch with both of you. Thank you both for your help this past legislative session and, just educating our community on best path forward, what everyone else is doing as we consider what's best for Hoosiers across the state. So thank you so much, and everybody we do have one more
polling question.
Yeah, I could see Sarah going, wait a minute.
I was like, wait.
And this is a really good polling question. This is a question that I would normally ask everyone if we were meeting live and have a panel discussion on, but we can't do panel discussions very easily now. But this is really regarding payment. So our current legislation around surprise billing just says take the patient out of the middle. You can't balance bill them, but we don't address payment. And payment's been a contentious battle at the federal level. And we just decided, it was a short session. We didn't have time to address it. It might get addressed next session, or it might not get addressed. Maybe we just keep government out of it. So I'd love to hear what everyone thinks about it. The question is regarding payment for out-of-network practitioners. What do you believe is the best strategy to pursue? State government should establish cap payments as a % of Medicare. In Indiana, we do have a law in the books that caps workman's compensation at 200% of Medicare. So I don't know if 200% is the right number, 250, 300, 150, I don't know what that number is, but do we need some sort of a cap? A state government should determine that health plans pay based on median in-network rate. That's what the strategy that some states have used. State governments would create an arbitration process, as both of our speakers have talked about. This arbitration process means that the government would have to establish arbitrators, and they would be given some guidance regarding how to determine, basically the hospitals would come to them and the insurers would come to them, and they would be the arbitrators and say this is the best price, or this is the price that we're going with. Whatever that price is, it's going to be above the in-network rate. Government should just stay out of the whole thing and let the market stakeholders, including practitioners, hospitals, health plans, and purchasers figure it out. And the goal really for Indiana just should be to keep the patient out of the middle and let everyone decide. So, do we need a payment solution? What do you think it should be? And then, or should we just stay out of it? Your thoughts would be really welcome. And then we will give everyone a minute here just to answer that and then show the results. And your comments do inform the direction that the forum will be going in supporting next legislative sessions. So I appreciate everyone taking a minute to answer this question. And if you have comments or thoughts about this topic, please email them to me. I'd be delighted to set up a call with any of you or a meeting with any of you just to get your perspective and answer any questions that you might have. All right, Sarah, you want to
Yeah,
share?
it looks like we have a few more people. I will let you guys have a few more seconds to answer. But it looks like a majority of the group has answered, which is
Great.
fantastic. Thank you guys. But I will be ending the polling. So sorry if you were not able to give your answer. So let me share these results with you all.
Interesting. So it looks like the majority of folks do think we should have a cap as a percent of Medicare. And then let's see. And then the second most is just stay out of it. Majority of, actually nobody, it says 0%, but then, oh, I'm sorry. Yeah, so nobody picked arbitration, which is interesting. I mean, I'm not a fan of arbitration because it just adds administrative costs and we're already paying so much and it's just going to be something higher than that. But, you know, our provider costs are less, you know, and I do want to make something clear when Loren mentioned that, and Sarah, you can make that poll go away. Magically, just magically goes away. So when Loren mentioned that slide that showed anesthesiologists, pathologists, radiologists, and what percent of Medicare they were getting paid, and it was between 200 and 350% of Medicare. When he first showed me that slide, I was like, that's nothing. That's what our baseline is here in Indiana. Like, that's, you think that's a lot higher? That's not higher for us. But it didn't hit me till just now during this presentation, Loren, those are professional fees. And our professional fees in Indiana are on the lower side. What I was thinking about was the RAND study and our hospital fees, which are 300, you know, around 311% as of 2017. So our professional fees, according to the Harvard study by Michael Chernow that was published in May in the Health Affairs Journal, showed that we were sitting at around 160% of Medicare. So yeah, your 200, 350 makes sense that it is at least double, if not triple, on the professional fee side when they're out of network. Excellent. So thank you everybody for participating in this meeting today. We will be recording this meeting and it will be posted. And we hope to continue the discussion in the coming months. Thank you and have a wonderful afternoon. Thank you to our speakers.